Hello everyone. Today we are doing a smaller lecture, kind of a niche thing. A lot of ICM in this presentation, or stuff that'd be beneficial for ICM, but I feel like it would be weird or awkward maybe if I just gave you, like, here are the antibiotics and here are the NSAIDs you're going to be using, and not give some context. So a lot of this presentation is context. So a lot of this stuff you don't have to stress about memorizing for my exam purposes. It may be beneficial for ICM. I don't know. I haven't looked at their exam or know what they're doing over there. But you know, again, a lot of this is going to be context. I think that's the best word. You'll hear me saying that a lot during this presentation. But I want you guys to focus on the drugs, because we like drugs in this class, right? That sounds bad. But yeah, we need to be focused on the drugs in this class. So that's good. It's appropriate. It's professional, right? So I'm going to definitely tell you guys certain slides I want you to star and highlight, pay attention to for testing purposes for pharmacology. But other than that, this is a great presentation. I mean, definitely read through all of it, look through all of it, even if I'm going through it kind of quick. But then for my test, just focus on the drugs. So this intro, again, just read through it, just to make sure everyone's on the same page. Everyone has a background of what we're talking about when we talk about ARF, which is acute rheumatic fever, and then gas, which I don't think people say gas. They say GAS, but this is group A streptococcus. So I mentioned when we went over the antimicrobials, you will be seeing antimicrobial type questions throughout the whole year now, Pharm 1, 2, and 3. So as promised, here you go. Hold your applause. No, I'm kidding. I know it's like everyone's groaning and it was a painful chapters and all that, but this is hopefully going to kind of, reiterate some of the stuff we've already learned, some of the stuff you've already been over, and then make your rotations that much easier, hopefully. So main bug we're worried about is group A streptococcus. Treatment. So we need to think about anti-inflammatory, which we haven't been over, but I'll highlight a couple. Don't stress too much about them. You will be getting those a full proper lecture on anti-inflammatory drugs. Antibiotics, you've already had those, but I'll highlight some. And then heart failure management, again, you've had some of that in this module, but don't stress about it too much for this presentation. Here's some goals of treatment, and the big reason we're talking about it today is because you want to get rid of the GAS, or the group A beta hemolytic streptococcus. So that is why we're here, but definitely read through all this. And like I said, this is all good stuff. And this is just another note too, just again, maybe more relevant for ICM. Definitely want to get rid of this infection in these people. You want to eradicate, hopefully, the group A strep. A lot of stuff going on this slide, but this is important. In particular, here, this third bullet, definitely put a star by there. This is what I want you guys to remember, as far as this is going to be your go-to #1 treatment to eradicate the group A strep in a person who has ARF, right? And it's an IM form of penicillin G. So hopefully these hyperlinks worked for you. If you want more information, I left the hyperlinks in there. So you hopefully can click on that, and that'll take you to Lexicomp, which is embedded in UpToDate. And then you can read more specifics on the penicillin G if you want. But take home point, it's an IM penicillin. And it's great because it should eradicate the initial infection, and then it's also used for secondary prophylaxis, which we'll be talking about. So it's something that if you can start with that and go, and then also use it for secondary prophylaxis. So most of the time, and I've mentioned this before in some of my presentations, you typically want to start with PO or with oral, but this is an instance where you want to do the parenteral, specifically intramuscular IM injection for this infection. So let me jump over to the table real quick, and hopefully that'll help you guys know. But definitely read through all of this, but let me jump over to the table. I think it's good. Okay, here's the table, and make it a little bit bigger. Again, this is from UpToDate. It's in my slides. If you have any trouble getting it, accessing it, or whatever, email me, and I will make sure you get a copy of this table, because I think it's very important. So put a star on this table, too, for all of you guys who are following along at home. But you'll notice that this is going to be your first line, what you're going to want to start with. IM penicillin, single dose. If and then if it's not available, if there's a shortage, if for whatever reason the pharmacy doesn't carry, or you guys can't get it as in your clinics or wherever you're working, then you can go with PO penicillin. So they have the oral Pen V, penicillin V, or amoxicillin, also cephalexins there too. And then, like I mentioned before, hypersensitivity is a concern with beta-lactam antibiotics, right? Penicillin, cephalosporins, notice that they have that here. Didn't just make that up, right? It's an up-to-date too. No, but if that's the case, then you can go to azithromycin, clarithromycin, and clindamycin. So you can go there are some alternatives there. Again, and because the penicillins are the preferred, and they are preferred by most experts, and as far as their coverage, etc., you want to make sure that the person has a true penicillin allergy. And there's some language I have in my slides, but you maybe even go to an allergist and everything. You want to make sure it's a true allergy. The other thing to note too is that people have a less of a chance of getting the hypersensitivity reaction or having an allergic reaction with an intramuscular penicillin injection than they do with an oral penicillin. So that's another reason too, where you may, even if a person has a document or it may say penicillin allergy, have penicillin allergy, that may be something to, the intramuscular may be okay to still give them the IM penicillin. As always, I'd like you guys to squint and pay attention to the fine print. One thing on the fine print, though, that may be a little bit confusing for students is that there's an asterisk here that corresponds to oral penicillin V, and it is the drug of choice for group A streptococcal pharyngitis. So that just means that as far as its effectiveness and its coverage, it's very effective and very good at eradicating group A streptococcal pharyngitis. But specifically in ARF, right, the experts recommend, guidelines recommend starting with IM penicillin. Part of that is because it's once a day dosing, and you actually give that to the patient, and so compliance is not an issue. So you notice here with oral penicillin, they're supposed to take 500 milligrams, BID, TID, 2 to 3 times a day for 10 days. So that's a lot of opportunity for a patient to miss their dose, to not finish their antibiotics. Because unfortunately, and you guys may have personal experience with this as far as your families, if any of you guys have family members like I do, where, classic family member to be like, well, I started feeling better like my 3rd day on my antibiotic, and I figured I didn't need any more, like whatever. It's just like, and it was giving me diarrhea and tasted funny and whatever. So that's a real, I'm kind of joking, and unfortunately some of my family members do this, but it's a real concern with patients just in general that they stop taking their antibiotics before they have finished the full course, or they forget, or they skip a day or whatever. And then, not only is it not treating their infection that they have and eradicating the microorganism that they're infected with, but it also increases risk of resistance. And then in the case of ARF, they're not getting better, right? So it's correct in saying that oral penicillin is the drug of choice for group A strep. But then again, because of the circumstances of the disease, the guidelines actually recommend IM penicillin as the number one choice. And again, that's in patients that don't have a true type 1 hypersensitivity reaction. So, I mean, if they get hospitalized every time they get penicillin or come near it, by all means, start with these other ones. And then to note that, that with amoxicillin, you guys will hopefully remember that you do need to adjust the dose if they have renal insufficiency. And then go ahead and read through the rest of this fine print too. I won't just read to you guys, but it has some good stuff there. Let me get back to the presentation now. So, like I said, pay attention to this slide. It's specifically what I highlighted, and go and read through it too. Again, I don't want to deter you guys from reading anything else here. And then there's that table that we just highlighted. It's a little bit bigger on my screen when I do it the other way, so I was thinking of just doing it that way. Treatment, so there can be also phyloderma, which is basically a skin infection. And so with that, you need to think about doing a topical antibiotic. So you guys will hopefully remember mupirocin, which is the generic for Bactroban. And then that's going to be your go-to drug for most patients for a topical application. And that's usually, it's 3 times a day for 5 days. Let me just double check that real quick. Okay, yeah, pulled it up on UpToDate real quick. It's going to be 3 times a day for 3 to 5 days, but the guidelines recommend actually 5 days. I read about it earlier. But so, yeah. And this is the Bactroban, like I said, mupirocin. They also make over-the-counter antibiotic ointments, which you guys probably are familiar with, like the triple antibiotic ointment, the TAO as it's abbreviated. That's actually not recommended. It's over the counter, and a lot of your patients will probably go to it, and they may already have started taking it. But you really want to go with prescription strength if a person does have this issue. And like I said, the mupirocin is a good choice for that. So that's going to be something that it's hard. Oh, excuse me. Man, I've been catching all my coughs for you guys. I haven't, but sorry about that. I have the allergies now. Today's the first day of fall, and geez. Anyway, sorry. I just don't have that cough button. But I was gonna say it's hard sometimes for us as pharmacists over the counter to know why the patient's buying it. And then too, sometimes they go get the ointment. They don't even come to the pharmacy and ask us. And so this will definitely be an instance where, you've seen them in the clinic, are they taking the over-counter ointments or not? Because they're not really effective. They're theoretically have some benefit, but again, guidelines, number one recommendation is going to be the mupirocin or the Bactroban, which you guys can write prescriptions for, right? Household contacts, just read through this, but again, this is just more ICM, just FY for pharmacology. Arthritis management, again, we haven't talked about the NSAIDs yet, the non-steroidal anti-inflammatory drugs, or arthritis or anything. It's going to be another module, another lecture, so stay tuned to that. You have already had some presentations on aspirin, so that's one that you are a little bit familiar with. But so historically, that was the first line, but nowadays people are moving away from that for a number of different reasons. They're sticking with the NSAIDs, in particular naproxen, which is listed here. So this is generic Aleve, which is over the counter, so your patients can get that over the counter. Or then there's also prescription strength of it, depending on the dosaging and the strength. And so that's going to be your go-to one. The aspirin has some issues, so you guys hopefully remember, it's not recommended in pediatric patients less than 12 because of the risk of Ray's syndrome. And so that's a ding on it too. The other thing is too, when you're dosing aspirin for anti-inflammatory effect, and again, this is something we'll dig more deeply into. Sorry, we'll dig more deeply into. Got a cough again, cough attack there. But with the NSAIDs, typically you have the analgesic effects at lower doses of aspirin, and then you have the anti-inflammatory effects at higher dosing. So with that higher dosing, you have increased risk of adverse effects with pediatric patients as well. And with adults too, but in particular pediatric patients. So you may see some older physicians, or it is kind of old school medicine, quote unquote. But nowadays, go ahead and stick with the naproxen. So take home point for my test, just if there is any questions about arthritis management, just remember NSAIDs and then specifically naproxen. There can be low dose glucocorticoids, but those are ones that it's not first line. And again, we'll talk about this more in detail, but basically because of their adverse effect profile, they have a lot more adverse effects you have to worry about, and etc. And they're usually less well tolerated than naproxen and aspirin. But if they are good anti-inflammatory medications. So if someone really needs some anti-inflammatory treatment, and they are allergic and or have some contraindication to taking aspirin and naproxen, you could go with a steroid, which is a synonym, by the way. So glucocorticosteroids or glucocorticoids, steroids, those are all synonyms. And like I said, we'll explain more of that as we go. And then you'll notice that NSAIDs are non-steroidal, but again, I'll stop talking. We're going to do more of that later. Arthritis management, just read through this. Some good stuff here, but as far as the drugs, I went over those already. Carditis management, don't really have to worry about medications here. Just read through this, and then same thing with severe carditis. Don't stress too much about it. Just basically, if they do have severe carditis, you need to go to conventional heart failure therapy. So, in which we talked about in other lectures. So, you can refer to that. Indications for valve surgery. Again, this is just for a complete picture. Just read through that. May be beneficial for ICM. I'm not sure, but not something that I will test you on. So the Sydenham chorea management, it's also known as rheumatic chorea, and this is any chorea is an abnormal movement abnormality, or and this is one specifically of the face and limbs that can affect some patients. So just read through this. There are some medications you can maybe use. So for example, carbamazepine or valproic acid that may help. But just go ahead and read through this. Don't stress too much about this for my course. The other thing too is that there can be a rash, and that you don't have to usually worry about it too much. You can use over-the-counter antihistamines, so oral or topical, and then first generation and second generation antihistamines. So like I said, they make some topical antihistamines that may be beneficial, and then if the patient wants or can tolerate oral antihistamines, they have the first generation of the older ones have more sedation, so that may not be an ideal for your patient. Excuse me. And then the newer second generation ones, which we'll get you those lists and everything, but that's like things like Zyrtec or Allegra, the ones that are over the counter, have less sedation and maybe a little less adverse effects, but that's something then that can help with the itchiness, the pruritus. Prevention, so this is another part that, again, it's a lot of just context and stuff for to give a complete picture for you guys. And go ahead and read through this stuff. Like I said, it's good stuff. Secondary prevention, squint a little bit more at this. This is where we're going to get into some more antibiotics. So secondary prevention has antibiotic prophylaxis. And again, there's another table, but the duration. So here we have the duration of therapy. Just go ahead and read through this and just know that it may be a pretty long time when you have to continue to do the secondary prophylaxis. So just go ahead and look at that. And here's that slide again. And then you'll note too, again, put a star by it, but the IM penicillin G is going to be preferred. And so this is part of the reason it's preferred when you initially treat, because then you can just continue to use it for antibiotic prophylactics for the secondary prevention. And then, as always, if they're not, and definitely read through this, etc., and make sure you look at all this. But then if they, can't be given the penicillin G, there is a third table that I'll pull up. So you'll see here again that Pen G IM is going to be your go-to first line choice. And then if they are allergic to penicillin, have a true allergy, and sulfonamide, you can go to zithromycin. So look at this chart as well. Make sure you guys pay attention to that. Let's get this. And go ahead and read through this. And then just note too, with the duration, that if it is more severe, or that there are some rationales for 21-day regimen versus 28. But that's not something I want you guys to really focus on, that stuff for test questions for me, but may be beneficial again for ICM. And then also, definitely when you're out in practice, if you have this patient, definitely remember that the duration can vary depending on the severity and what specifically is going on with the patient. So here's that table again. And then this is a note too that just, again, it's more evidence showing that the Pen G IM is going to be your go-to choice. And then here's some antibiotic selections if they can't tolerate, or you can't get the IM Pen G, or whatever, if the patient can't tolerate or whatever, you maybe go to the macrolides, maybe go to a sulfa medication. But those are less frequently used. So definitely put a star by here too, and I want you guys to, again, pay attention and focus on these antibiotics. This one too, just read through it. It's good stuff, but anyways, this kind of touches upon the point I was making earlier about how compliance is a big deal, and so the intramuscular administration can help you ensure that the patient's actually, taking all their antibiotic. And then too, just note that there's ways and techniques that you hopefully will be learning in your labs and stuff about how to administer these IMs, that because patients complain about the pain, and people don't like injections in general, but then these IM, I don't know if you guys have ever had an IM injection, but they can be painful. So anyways, just read through that. So that is it for that presentation. Hopefully it wasn't too painful, but main take-home point, focus there on the drugs, right? We love drugs, and hopefully me going through it will kind of help you sort of focus on those things there. And as always, if you have any questions, feel free to email me. And thank you guys for your time and attention. I always appreciate that. I'll talk to y'all later. Bye.